Hi, I'm Rachel Butler Pagnotti, and today I'm going to be presenting on research I conducted with Justin Miller at Nevada's Exploratory ADRC and Cleveland Clinic Lou Ruvo Center for Brain Health in Las Vegas. Based on autopsy studies, late is thought to be the second most common neurodegenerative disease in the oldest old, or those over the age of 80. However, little is known about the cognitive profile and trajectory of impairment in patients with late and how this may differ from those with Alzheimer's disease. Our study aimed to investigate the cognitive and clinical characteristics of patients with just late at autopsy and how these differ from patients with just Alzheimer's disease and patients with comorbid late and Alzheimer's disease pathology. We analyzed data from 686 participants' initial NACC visits. We included individuals who had autopsy data and had died after the age of 75, and we excluded individuals with clinical diagnosis or neuropathological indications of FTLD, multiple systems atrophy, Down syndrome, ALS, or prion disease. We had 31 participants with late pathology at autopsy, defined by this criteria listed here. We had 393 participants with Alzheimer's disease based on the National Institute of Aging and Alzheimer's Association criteria, and we had 262 participants with both late and Alzheimer's disease on autopsy. Looking at participant demographics, we found no significant differences between these three groups in gender, race, handedness, or education. We found that participants with late had more UDS visits in total, presented with cognitive decline later in life, and were older at the time of death. Compared to patients with Alzheimer's disease or comorbid AD in late, participants with late tended to have a shorter disease duration by about 3 years, which could indicate a more rapid decline from onset of symptoms to death. Next, we looked at different cognitive characteristics. First, we looked at the group consensus diagnosis, so what was the participant diagnosed with at their initial group consensus conference. Out of the three groups, participants with late had a higher percentage or higher likelihood of being diagnosed as normal cognition compared to those with Alzheimer's disease and AD in late. We also found that participants with late were significantly less likely to self-report memory decline as one of their initial symptoms compared to the other two groups, and we found a similar pattern when co-participants were asked to rate the participants' memory decline. Looking at cognitive performance, we used neuropsychological measures from the Uniform Dataset 1 and 2. We had to look at raw scores because UDS 1 and 2 only reports raw scores and not norm scores. So for global performance, we looked at the MMSC, which is out of 30 points. For memory, we looked at logical memory learning and delayed recall, which are both out of 25 points. Semantic fluency, we looked at animal naming and vegetable naming. And for Boston naming or semantic knowledge, we used the short form, which is out of 30 items. We found that participants with late had significantly higher raw scores on each of these different tasks. They consistently performed better than individuals with just Alzheimer's disease. And consistent with the literature, we found that patients with both Alzheimer's disease and late performed significantly worse across tasks. So in conclusion, participants with late were more likely to be classified as cognitively normal at consensus diagnosis by a group of well-trained clinicians on objective screening like the MMSC and based on self-report and caregiver report questionnaires. We also found that participants with comorbid Alzheimer's disease and late had consistently worse cognition than those with just late or those with just Alzheimer's disease. Because they look cognitively normal across different measures, participants with late may be misdiagnosed as healthy controls. This can have a huge impact on clinical trials for Alzheimer's disease interventions because contamination of patients in a control group with abnormal neuropathology could undermine the ability to detect the impact of the intervention. This research highlights the importance of including Alzheimer's disease biomarker data in determining clinical trial enrollment for Alzheimer's disease intervention trials. I'd like to take a moment to acknowledge the grants that fund my fellowship, Dr. Miller's work, the Nevada Exploratory ADRC, as well as the NACC database. And here are a list of my references. Thank you for listening.